everybody. Thank you guys for joining me tonight. I know this was just very last minute. I was just thinking, I was like, hey, I'm about to record a YouTube video. Why don't I just have some people join me tonight so I'll be able to interact with somebody? It makes it a lot more fun for me instead of just sitting in the room by myself. So welcome everybody. If you don't mind, turn on your camera so that I'll be able to see all those beautiful faces. Jalen, we got Maris, we got Taylor tonight. We got Zoom user. I don't know who you are. What's your name?
Jonathan.
Jonathan. Hey, which Jonathan are you? We've got two.
Wallace.
Wallace. Hey, man. How you doing?
Good. How are you?
Doing well. You're actually new to the community. Welcome, welcome, welcome. So
yes,
tonight,
sir,
what
you.
I wanted to do is I was thinking about, this concept that I teach of oxygenation, ventilation, perfusion. And I tell you guys all the time that this is like the bread and butter of everything. If you can get everything down to this on the test and in real life, it just makes your thinking so much simpler, because now it's like, I know what the actual problem is. So what I wanted to do is just kind of go through that. For those of you who've already been in the program, you're very familiar with it, but perhaps I may say something that's a little different tonight, or I may make another connection for you. Like, I'm even going to add a little more to the story tonight, because I always want you guys to understand the how and the why. Remember, I say there are 5 levels of learning. Level 1, in fact, let's just draw it out. So level 1, okay, level 1, this is where all right, so 5 levels of learning. Okay, level 1 is where you know what something is. So maybe I'll draw a rhythm and I say, okay, what is this rhythm? And you say, I know what that is. That's V-fib. That's what it is. Okay, or I say, okay, what is this rhythm? And you say, oh, I know what it is. That's called A-fib. Well, level 2 knowledge is where you know what the protocols say do about it, okay? The challenge is this is where most people are their entire career. They only have level 1 and level 2 knowledge for their whole time, and their knowledge actually gets worse over time because they're not keeping up with things, okay? Where the magic happens is when you get to level 3 and you understand the how and the why. You guys have heard me talk about my mentor, Dr. Francis. The biggest thing that I learned from Dr. Francis E. Hedgerika was, he said, hey guys, you need to know normal. You guys are trying to memorize diseases and you're trying to memorize abnormal, but you don't know how the body normally works. In order to understand disease, you first must know normal, and then abnormal, as he would say, just smacks you in the face, okay? When you understand the how and the why, 2 things that will help you a lot is understanding the biochemistry, but even more importantly, understanding the physiology, the how things work, okay? Level 4 is where you apply it. You take one concept and go apply it all over the body, okay? Like I take a concept like depolarization. Depolarization just means that the inside of a cell becomes really positive. But if I take that one concept, I can now apply it all over the body. Let's say I have too much depolarization in the brain. All right, so we're going to take one concept. We're going to call it depolarization. What is depolarization? It's where I have too much positive activity on the inside of the cell, and that causes some problems. It's good to be positive in real life, but in the cell, too much positive is a bad thing. Too much is bad. Positive is good. Too much positive is bad inside the cell. But let's say I go up in the brain and I have too much positive stuff going on. What do we call that? That's called a seizure. Okay. Now, what if I go into the heart and I have too much depolarization? What's that called? That's a tachyarrhythmia. Okay. What if I go into a muscle? Let's go into a muscle. If I have too much depolarization in a muscle, what do I call that? That's muscle cramps. Okay. What if I have too much depolarization in the eyelid? What do I call that? Blepharospasms. Okay. What if I'm in the GI tract and I have too much depolarization in the GI tract? What do I call that? Diarrhea. Okay. So all I did is take one little concept and apply it a lot of different ways, and I call it a different name. Okay. Let's take another concept. Let's say I take this concept of inflammation. Okay. If I take that same concept called inflammation, let's just apply it in a lot of different ways. If I have too much inflammation in the brain, we're going to call that increased intracranial pressure. If I have too much inflammation in the heart, we're going to call that like myositis, or I'm sorry, like carditis. It could be endocarditis, myocarditis, pericarditis, but too much inflammation of the heart, we're going to call that some kind of carditis. What if I have too much inflammation of a muscle? Now I'm going to call it myositis. What if I have too much inflammation in the GI tract? Well, now I'm thinking about things like irritable bowel syndrome, Crohn's disease, things like that, right? All I did was take a basic concept and just apply it a lot of different ways and change the name. And so sometimes when we do that, people think it's like totally different stuff. All I really said was inflammation, 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 inflammation. I just changed the name. And so it seems like it's a totally foreign concept. This is why you want to know the information so well. And then finally, level 5 knowledge is where we get to mastery, hopefully, or at least we should get closer to mastery. We will never really get there because there's always so much more to know, but the more we know, the better we're going to get. Okay, so there are 5 levels of learning. Now, you guys have seen me draw this one picture over and over and over again, but I want you to recreate this one picture for yourself. And I want you to see how if we can get everything down to this, it makes things so much simpler. So this is where I want you to participate. So Jonathan, you're on, is your camera on?
Yes, sir.
Okay. You okay if I pop you up on the screen?
Absolutely.
All right, my man, let's go. Let's see if I can get you up here. Let's see. This is, hold on. I need camera shot 8. Let's see if that works. Yep, there you go. Oh, wait, I got 2 of you and no me. All right, let's see if we can swap that out so I can show up. Now we're cooking. How you doing, my man?
Good. How are you?
Okay, doing well. So you're new to the program, so you hadn't really heard all this yet, or you may have heard some of this if you, depending on how far you've gotten. Okay.
Yes,
so here's
sir.
what we're gonna do, and this is for everybody. And I want you to take a blank sheet of paper, and I want you to recreate this, and I'm gonna show you how useful it is. Okay, so I want to say Jackson, but that's another guy, Jonathan. Jonathan, everything we do in medicine comes down to 3 things. So we got a triangle here. We got 3 sides, right? So everything comes down to this concept called oxygenation, ventilation, and perfusion. So the way we're going to remember that is we're just going to call that OVP. I think it was Amanda who said that. OVP. Yeah, you know me. So everything comes down to OVP, oxygenation, ventilation, perfusion. Right, Jonathan?
Yes, sir.
Okay, so let's talk about it. Oxygenation is all about, now for those of you who've heard this 100 times, that's okay, because I'm going to put a little more to it tonight, and we're going to explain even more. Just stay with me. I just got to hurry and get to that part. So, Jonathan, oxygenation is all about getting oxygen into the body, oxygen in. Okay? What is oxygenation all about, Jonathan?
Getting oxygen into the body.
Oxygen into the body. Okay? So, you know this. Oxygen has to come in, and then what goes out?
CO.
Okay, not CO, that's carbon monoxide, but CO2, which is carbon dioxide, right? So oxygen comes in, carbon dioxide goes out, and then blood goes round and round, right? So you've heard air goes in and out, but the oxygen goes in, the carbon dioxide goes out, and then the blood goes round and round. All right, let's make some sense of this. The reason I have to get this air into the body, the reason oxygenation is so important, is I need everybody just follow me for a moment. I need this oxygen to go all the way down. I need it to get all the way through the upper airways, the lower airways, through the lungs, get down in here in the alveoli, cross over into this alveolar capillary membrane, into the capillaries, and then I need it to get into the bloodstream. Boom, oxygen is now in the bloodstream. Once it's there, what can it do? This oxygen can now go to the most important organ in the whole body, the brain. There's our oxygen in the brain. Now, what happens if I don't have enough oxygen going into the brain? What are some reasons that oxygen would not go into the brain? Well, watch this. Let's look at it from the picture. Let's not memorize anything. Let's let the picture give us all the answers. Watch this. What are some reasons that oxygen would not make it through? Well, check this out. What if I block the airway? Okay, if I block the airway, now oxygen can't get in. Make sense? Now, what are reasons that the airway could be blocked? Oh, well, I don't know. Maybe they're unresponsive. Their tongue falls down to the bottom, to the hypopharynx. Make sense? So they can have an obstruction. What if I have fluid here? What if I have dentures here? What if I have blood here? Right? Any of those things. Oh, what if I have some kind of narrowing of the airways? If I have narrowing of the upper airways, what sound does that produce?
Strider.
Stridor. Okay, so if I have narrowing of the upper airways, that's stridor. What if I have narrowing of the lower airways? What's that called?
That'd be wheezing.
That's going to be wheezing. So there again, that's an airway problem. All right. Now, what are some other reasons that air couldn't get in? Okay, so let's open this airway back up. What are some other things that could happen? Oh, what if I have fluid in the airway? Now, as this oxygen tries to go in, it can't. What are some reasons that I would have fluid in the airway? Well, it could just be mucus or pus in the airway, or like in the upper airways. What if I put it, let's take that same fluid and let's put it down in the, way down in the lower airways. Oh, that could be pneumonia, pneumonitis. All right, let's put it way down in the pulmonary capillaries. Oh, that's going to be pulmonary edema, right? So all I'm doing, I'm taking the same picture and we're just going to come up with reasons that it could fail from this one picture. Okay. Now, give me some other, type in the chat, everybody. What are some other reasons that we could not get air into the body? Now, okay, in order to be able to take a breath, you have to have, all right, so what's this big muscle down here? This dome-shaped muscle that looks like that. What's that big dome-shaped muscle that when it contracts, it goes down? Down.
Diaphragm.
Diaphragm.
Diaphragm. Okay. And what's the nerve that powers up the diaphragm? What's that nerve called?
The phrenic nerve.
Phrenic nerve. Okay. So what if I have damage to my phrenic nerve? Okay, that could have been due to trauma, some kind of spinal injury. What if I damage my phrenic nerve and now my diaphragm doesn't work? Now I'm not able to contract the diaphragm and now I can't get oxygen in. Okay. So all I did was I'm not memorizing a PowerPoint. I'm literally coming up with this on the fly right now in front of you with no notes or anything, just from the picture. Okay. Now watch this. Watch me go through the whole story to teach you why all of this stuff is happening. Okay. Now, when I can't get air into the body, when I can't get air in, what's going to happen to the respiratory rate? If the body's saying, hey, give me some air, I need my air. What's going to happen to the respiratory rate, Jonathan, if I need more air?
Gonna go up.
So this is why one of the first symptoms that we see in almost all sick people is increased respiratory rate, and it produces symptoms. So we're going to say increased respiratory rate with symptoms. Now watch this. As that respiratory rate continues to go up and up, what has to happen for the heart rate to keep up with it, to move more oxygen? If they're not bringing it in and the oxygen has to go through the blood, what has to happen to the heart rate to move more blood?
It's got to increase.
Whoa. Oh, I'm getting too excited over here. Hang on. Okay. So check this out. So the next thing that has to happen is we're going to have an increased heart rate, and that's going to produce symptoms. Okay. You following me so far, Jonathan?
Yes, sir.
All right. Now, all right, let's give Jalen let's give you a break for a minute. Don't go anywhere. Let's bring Jalen in. All right. So Jalen, when this heart rate continues to go up, because the blood pressure equation or the perfusion equation is heart rate times stroke volume times resistance. And heart rate times stroke volume is cardiac output. As this heart rate continues to climb, it pumps faster, but it doesn't have enough time to fill. So it's pumping, but it doesn't have enough blood. So what's going to happen to my stroke volume? My stroke volume is going to go way down. So what started off as an oxygenation problem is ultimately also going to result in a perfusion problem. And what do you call it when I have too much decreased or hypoperfusion? What's that called, Jalen?
Stop.
That's called shock. Okay. So the end point of not getting enough oxygen, the end point is shock. Okay. That's oxygenation. Now, one thing let me back up for a second. So you guys have seen me do this, but for the benefit of those who haven't, remember this is our kind of continuum of how everything progresses. So we have ischemia, which is a lack of blood flow. Then we have hypoxia, which is a lack of oxygen. Then that's going to lead to respiratory distress where they're having trouble breathing. They are breathing, just not breathing too well, or they're having trouble. That's going to ultimately lead to respiratory failure. Respiratory failure is where they're not compensating anymore. They can't keep up. That's going to ultimately lead to respiratory arrest where they get so tired they just quit. And respiratory arrest is once their respirations go down to zero. And then ultimately, when they're not breathing, remember there's no oxygen coming in, there's no CO2 going out. That's going to ultimately lead to cardiac arrest. Now, let's talk about how all this stuff happens. So let me back up. The way we're going to fix an oxygenation problem is either we do something with the airway itself or we add oxygen so more oxygen can come in. And the way we're going to add oxygen is through some kind of oxygen delivery device. Well, if they're in mild distress, we're going to use a nasal cannula. Jalen, what's our flow rate for a nasal cannula? A regular nasal cannula?
1 to 6.
1 to 6 liters per minute. My man, check you out. Now, what if we have a capno nasal cannula, the green one?
1 to 5.
All right, that's going to be 1 to 5 liters per minute. Okay. Now, what if we have moderate distress and we're going to use a non-rebreather? What's our flow rate there?
12 to 15.
All right, that's going to be 12 to 15. And what about a nebulizer?
6 to 8.
6 to 8. Okay. All right, I hear you talking, but your mouth isn't moving on my screen. We got a ventriloquist.
It's probably because it's slow.
Okay, no problem. Okay. Or if they're in severe respiratory distress, we're going to use CPAP. All right. Now, I said all that just so I could get to the ventilation part. Now, for those of you who've been around a little bit, you know that I've said a ventilation problem is once they get into respiratory failure. So notice how everything is color-coded. The red all matches perfusion. Okay, so ischemia, cardiac arrest, those are perfusion problems primarily. The blue, that matches the oxygenation. So hypoxia, respiratory distress are primarily oxygenation problems. The purple matches ventilation. So respiratory failure, respiratory arrest, those are ventilation problems. Now, ventilation is all about getting the CO2 out. Now, so Jalen, you've heard me say this. I said, why is too much CO2 a problem? Why is it that we got to get rid of all this CO2? Why do we not want too much of it hanging out? Because excess CO2 leads to what, Jalen?
Acidosis.
Okay, acidosis. Now, I've told you that, but do you know how? How does excess CO2 lead to acidosis? Where does the acid come from? Have any idea? Does anybody know?
CO2 behaves like an acid.
Okay, but how? Like that's what the books say, but how does CO2 behave like an acid?
Not sure.
Come on. Okay, so let's do it. I couldn't wait for this. Okay, so here's what's going to happen. Watch this. We have all this CO2 laying around. Now, what substance is your body made up of mostly? The whole human body, what is most of the body made up of? If you got to pick one substance, what's the one substance that is all over the body? What's the one molecule that's, say it again?
Water.
Water. Ooh, check you out. So watch this. So the CO2 ends up hanging out. It goes to meet all this water hanging around. Now, notice what I have here. I have 1 carbon and 2 oxygens. And then I have 2 hydrogens and 1 oxygen. Let's add it all up together and see what it leads to. So now I have some hydrogens, I have some carbon, and then I have some oxygen. Okay? So I have hydrogen, carbon, and oxygen. How many hydrogens do I end up when I put these two things together? How many hydrogens? Oh, well, there are two of them. So let's put two of them. How many carbons do I have? Right here. There's a carbon. There's a carbon. How many oxygens do I have? Well, I got two here and one there. If I add that together, that's 2 plus 1. And how many is that? That's 3. Wait a minute. H2CO3, what's that called? Oh, that's called carbonic acid. That is how excess CO2 leads to acid. Okay? Now, excess CO2, that carbonic acid is going to further dissociate, and it's going to break apart, and then now it's going to be left with some hydrogen, and it's going to be left with some carbon and some oxygen. Well, if I take one hydrogen here, that's just one. But remember, I started with 2. I got to put in another one somewhere. I can't just like make it go bye-bye. It's got to go somewhere. So let's add a hydrogen there. And then remember, we still had these 3 oxygens. So let's put those 3 oxygens back there. Now I end up with hydrogen plus HCO3. That's bicarb. So excess CO2 is going to ultimately become an acid. And then that carbonic acid is going to lead to hydrogen plus bicarb. But watch this. All this extra hydrogen, once it goes over and gets into the blood, now that creates more acidosis. So that's why when I tell you that excess CO2 leads to acidosis, that's where it's coming from. Now check this out. So if I now put all this, let's take all this hydrogen and put it in the blood. Let's take all this carbonic acid and put it in the blood. Now, if I got all this, so I had some kind of respiratory problem that's causing acidosis. Wait a minute, let's put those two words together, respiratory and acidosis. Oh yeah, what would that be? Oh yeah, that sounds like respiratory acidosis. So one of the first things that's going to happen when you have too much CO2 is we're going to ultimately come up with respiratory acidosis. Okay? So notice how just not breathing well is also going to affect your acid-base balance. Let's keep the story going. Remember I said we're going to put all this acid in the blood? Everybody still with me? Give me a thumbs up if you're still with me. All right, so we're going to put all this acid in the blood. Well, let's do some stuff now. Let's make this acid go places. Check it out. Let's put it in the blood. Ooh, now that it's in the blood, it's on the superhighway. It's going to go to the brain. Whoa. All right, so now once I put all this acid in the blood and it now travels to the brain, watch this. Let's travel. Let's take acid. Boom, 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 boom. Let's go up in the brain. All right, once we're up in the brain, check this out. We're going to go to these blood vessels in the brain. Let's dilate these bad boys because all this acid, remember I told you that acidosis leads to vasodilation. What if I dilate these veins up here in the brain? Remember, the brain is inside of a skull. So the skull can't move because that's bone. But if I keep putting more, if I dilate these blood vessels in here, what is that going to do to the amount of blood that's flowing inside the head? If I dilate them, if I make the pipes bigger, here, Jalen, we'll take you out for just a minute. If I make the pipes bigger, what's that going to do to the amount of blood inside the head, inside the brain?
It'll drop.
If I make the pipes bigger. Talk back to me. Just unmute.
It's going to drop. It's not enough.
Okay, well, if I make the pipes bigger, does that allow more blood to flow
More
or
pressure.
less blood to flow if they got bigger pipes?
More blood flow.
Okay, so if I make the pipes bigger inside the head, that allows more blood to flow. If I keep funneling more and more blood inside the head, what's that going to do to the pressure inside the head?
Increase cranial pressure.
Aha, so now I have increased intracranial pressure. This all came from not ventilating. This is why ventilation is so important. This is why we got to get rid of that CO2 because these are all the things that start to happen. So we're going to have increased blood flow in the brain. That's going to increase the pressure in the brain. That's now let's put more and more pressure. Well, let's knock out the brain stem. Now I just caused herniation. So I had increased intracranial pressure that now just caused herniation. Oh, let's herniate some more. Let's get down here in the medulla oblongata of the brainstem. That's where our respiratory center is. Let's knock that out. Let's just wipe out the respiratory center. Let's just stop them from breathing. So now this is how the patient goes from respiratory distress to respiratory failure to respiratory arrest. Does that make sense? Make sure you catch this back in the replay so you can go step by step with me. But I want you to know the how and the why everything is happening. Okay? Any questions about that? Okay, but hold on, I'm not done yet. So not only does all this acidosis, once it gets into the blood, when it goes to the brain, it's going to increase the volume in the brain because it dilates the blood vessels. So now I got more blood just going into the head. That's going to lead to more pressure. That pressure is going to cause increased intracranial pressure. It's going to cause herniation. It's going to cause respiratory arrest. Okay? Or irregular respirations that lead to respiratory arrest. What triad did I just describe?
Cushing's.
That's Cushing's triad.
Cushing's.
That's the how and why of Cushing's triad. Now, so what else happens though? Not only do we affect the brain, let's go over to the heart. All right. Now, when I take some of this acid that's flowing in the blood, let's send some of it to the heart. Now, when I put a whole bunch of acid going through the heart, what's it going to do? It's going to irritate the heart. Oh, let me back up for a second. Let's talk about the brain, though. What else is this acid going to do inside the brain? I'm coming back to the heart. Let's talk about the brain again. What else is this going to do? Well, if I now put a whole bunch of acid in here in the brain, this patient is now going to become sleepy, lethargic. They're going to be altered. This is why in every situation of shock, the patient becomes lethargic, sleepy, obtunded, slow to arouse, have altered mental status from the exact same thing. All we're doing is these are just multiple effects of the exact same situation. But now instead of just memorizing, oh yeah, we're probably going to have increased heart rate with symptoms, increased respiratory rate with symptoms, altered mental status, I want to explain why every one of these things is happening. Okay, now, so in the brain, the brain ultimately is going to get sleepy because of this acid. In the heart is going to get irritated. That's going to lead to dysrhythmias. This is how one of these dysrhythmias can ultimately lead to cardiac arrest. Okay? Any questions about that so far? Okay, now let's talk, first of all, any questions? Is everybody still with me? Okay, any questions? Okay, let's keep going. Now let's talk about some possible reasons. So test questions, all they do is take a concept. Remember how I said, let me go back. Remember how I said you want to be able to take one little concept and apply it a lot of different ways. That's exactly what the National Registry does. All they have to do is take one little concept called ventilation. We can now come up with 50 or 100 or 1,000 questions right now on the fly for ventilation. And then all we got to do is change age, gender, stuff like that. And now that's another question. The concept didn't change. It's just what questions they asked changed. The concept still comes down to oxygenation, ventilation, perfusion. Now watch this. What are some situations, type in the chat or just come off mute for me. What are some situations that would cause this person to breathe very slowly? Like, so after they get really tired, they start breathing slowly. And when they breathe slowly, they hold on to the CO2. When they hold on to the CO2 links up with the water, forms carbonic acid. That's acid. That carbonic acid dissociates into hydrogen plus bicarb. The hydrogen in the blood, that's more acid. So now we got acid here, acid there. Now we got acidosis. The acidosis gets into the bloodstream. When the acidosis goes to the brain, they're going to be altered, sleepy, obtunded, lethargic, somnolent, any of those fancy words. All I'm saying is the brain's not working because the brain's getting sleepy. Okay? In the heart, when this acid goes to the heart, it's now causing like dysrhythmias. This is why acidosis is one of the killers in the trauma triad of death. What are the three killers? Acidosis. What else? Coagulopathy and
Hypothermia.
hypothermia. So I don't want you to remember that. I don't want you to just memorize acidosis, coagulation, hypothermia. I want you to understand why acidosis kills people. Have I kind of made the story make a little more sense of why acidosis is a killer in trauma?
Yes.
Okay. Now let's keep going. So let's just on the fly, let's use this picture and let's just come up with some reasons why they're not able to ventilate and blow off the CO2. What are some reasons that would slow down their respirations? Well, we just said it. One thing was we had increased intracranial pressure. What are some causes of increased intracranial pressure? So here's what we're going to do. Let's go over ventilation problems. Well, we have increased intracranial pressure. What could cause that? Head injury. What else could cause that? Just hypoventilation. Just hypoventilation, period. Okay, so now let's take this word hypoventilation and say, what could cause somebody not to breathe well? What are some things that could slow down somebody's breathing?
Opioid overdose.
Let's go with opiates. Let's go with benzos. What else? We could have trauma. We could have too much pain. It just hurts to breathe. What else? What else? Some other things that could cause, okay, what if I have a neuromuscular disorder? All right, what are some examples of that? Oh, well, I don't know, myasthenia gravis, Lambert-Eaton myasthenic syndrome, lots of things could cause somebody to have there's a whole list of neuromuscular disorders, but any neuromuscular disorder could cause hypoventilation. But all I got to do in the test question is I can just make a scenario about opiates. Oh, you respond to such and such female, whatever, they got pinpoint pupils, suspected overdose. It's a ventilation problem. Okay. Or, oh, this patient was taking midazolam, Versed, Ativan, lorazepam, diazepam, right? They were just taking some benzo. Oh, yeah. Oh, this patient, they drank too much alcohol. Now I got alcohol overdose. But do you notice that each one of these situations, they're all just ventilation problems? That if you focus on all the details, it's easy to get tripped up. But if I can just get it down to, well, yeah, I know these are details. These are just details. What's the actual problem? Oh, yeah, it's a ventilation problem. What's my fix for a ventilation problem? What's my fix for a ventilation problem?
BVM.
All right,
Airway adjunct.
BVM. So in all of these situations, and do we use BVM by itself?
No, airway adjunct.
Okay, we're going to use an airway adjunct. That's adjunct. Plus, what else are we going to use?
Oxygen.
We're going to use high flow O2 typically. So BVM, remember, it's the three stooges, airway adjunct, BVM, high flow O2. All right. But do you realize that all I got to do is just get it down to what's the problem? Don't get lost in all these little details, no matter what the details are. Can you see how many questions we could come up with from this? But it still came down to one concept. Does that make sense? Now, sure, they could present this as 50 questions for you. It's still one concept that's being tested just 50 different ways. Am I making sense, everybody? Anybody else excited or just me?
Yeah, you are making sense.
Okay, good. All right, any questions on that? Any questions?
Are they, when it comes, I have one.
Yeah, go for it.
So I know you said if you just break it down to always knowing if it's just a ventilation problem.
Oxygenation, ventilation, or perfusion.
Yes, but I'm just saying for specifically ventilation problems.
Okay.
Will the like signs and symptoms, are they particularly like similar most of the time, or?
Yes. So, okay, it just kind of depends on what time period you're talking about. You're saying like, are these symptoms of increased respiratory rate? Now, okay, initially, so it all kind of depends on at what time do you get to the patient. They started with certain symptoms, but let's say it took you 20 minutes to get there, they may have progressed to different signs and symptoms. So initially, we're going to have increased respiratory rate with symptoms, increased heart rate with symptoms. That's what you're initially going to have when you have an oxygenation problem. Notice where I have it on what side. But as the patient gets more and more fatigued, they get tired. So first they're like, come on, breathe, 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 breathe. And then they start getting tired. And so when they start getting tired, how do they breathe when they're tired? Now we're going to have decreased respiratory rate with symptoms. So we first had tachypnea, but now we have bradypnea. So as we progress to respiratory failure, we'll either have a super high and shallow, or we'll have a really low respiratory rate. Both of those are equally dangerous. Okay? So these are different symptoms, but it's a continuum of the same problem at just different moments in time. Does that make sense? The same thing with the heart. So initially, the heart rate is up. But as the heart gets tired, it can't keep up anymore. The SA node is like, hey, look, I only like going 60 to 100. All this 150, you're stressing me out. So the heart rate starts to fall after a while. This is why later in shock, you're going to have bradycardia. You're going to have a decreased heart rate with symptoms. Okay? So, but just from this one picture, we've talked about why you have increased heart rate with symptoms, increased respiratory rate with symptoms, why you'll later have a decreased heart rate and respiratory rate with symptoms. Now, we also talked about why you have altered mental status. When you're not breathing well and you get all that acid in the brain, that produces altered mental status. When you're not oxygenating well, you don't have oxygen making it all the way through to get to the brain, so there's no oxygen. Now you have altered mental status. If the blood is not flowing well, or if there's not enough, these are glucose, if there's not enough glucose in the blood to get to the brain, now you don't have enough glucose, now you have altered mental status. Just right there, that's 3 reasons for altered mental status. Okay, now, why do you end up with hypotension later in shock? Early, you don't have hypotension. Early in shock, the blood pressure could be higher. It may even be normal, but later you have hypotension. Somebody want to take a stab at it from the picture? Because I don't want you to just memorize just random bullet points. I want you to understand the how and the why. That's where the magic happens. That's what separates the 3,000 level medic from the mediocre or the 950 medic. Okay? Why would I later have hypotension? I need you to explain it from this one picture. Where does the low blood pressure come from? I'm not talking about they're losing all their blood. I'm just saying in shock period, regardless of the type of shock, it all can result in hypotension eventually. How? Or why? Somebody tell me. Okay, Taylor, no problem. Somebody tell me. Just come off mute. Take a stab at it. It's okay if you're wrong. That's why we're here.
I would say something about maybe vasodilation causing a decrease in stroke volume.
Okay, I like that. And okay, so I like how you're saying it. As that heart rate continued to go up, stroke volume continues to go down. Well, eventually, the heart rate can't keep up. So eventually what happens is the heart rate will actually start to come back down. Remember I said that the heart rate starts to come back down eventually? As this heart rate starts to go down, and then now because the heart is stressed out and it can't function as well, the stroke volume starts to go down. And when the heart rate, and then when you dilate the blood vessels, the systemic vascular resistance starts to go down. When you make all of these go down, the obvious end result is the blood pressure goes down. That's our hypotension. That's how we end up in hypotension as a late sign of all shock. Okay? Does that make sense?
Yeah.
Okay. Now, so let's talk about, okay, now we've talked about shock, but now I want to tie it in kind of a different way. Remember how I said how we have the heart pumps blood. What's the rest of it? You know it.
Through vessels unless
Through
blocked.
vessels unless blocked.
Through vessels unless blocked. Okay. And of course, those are the four main categories of shock. So if the heart is not working well, that's going to be our cardiogenic shock. So if I wipe out my heart, now I don't pump blood, that's my cardiogenic shock. If I lose all my blood, well, now I lose my blood. There's no blood to move. And if there's no blood to move, no blood goes to the brain. If no blood goes to the brain starts to die. We're going to have altered mental status there. Okay, so this is why here I can have altered mental status. Here I'm going to have altered mental status. Now, what if about these blood vessels? As these blood vessels continue to dilate, the pipes get really bigger. We're going to have increased blood flow in certain areas, decreased blood flow in other areas. But when I have more dilation, that's going to drop my resistance. And when I drop my resistance, that's going to drop my blood pressure. So this is why, especially in the distributive shocks, our anaphylactic shock, our septic shock, our neurogenic shock, we can definitely end up with hypotension. Now, yes, in neurogenic shock, initially you're going to have hypertension because your body is saying, hey, I'm trying to do everything possible to send some blood to the brain because it's the most important organ. But now when I send more blood to the brain, remember that same story from earlier. When I send more blood to the brain, I increase the volume in the brain, but I also increase the pressure in the brain. So that leads to increase in intracranial pressure, that leads to herniation, that leads to respiratory arrest, and later cardiac arrest. Okay, now what if I have these these obstructive shocks? So, okay, let's make sense of, so under my obstructive shocks, remember we have like a tension pneumothorax. What else? Give me some other causes, big causes of obstructive shock.
Cardiac tamponade, PE,
All right, so
MI.
cardiac tamponade. And what else?
Pulmonary embolism.
Pulmonary embolism. Okay. Now, let's make sense of each one of those. In tension pneumothorax, what are my big signs that happen?
Diminished breath sounds.
Okay, so I'm going to have decreased or absent breath sounds. Oh, wait a minute. Hold on. If I have decreased or absent breath sounds, that means that one side of the lung is not fully inflated. Make sense? Are we good so far? We're going to use the same picture and let's come up with the how and the why. So what we're talking about right now is tension pneumothorax. Let's understand why you have the symptoms you do or the signs you do in a tension pneumothorax. You said you're going to have decreased or absent breath sounds. If I have decreased or absent breath sounds, let's just collapse one of these lungs. All right, here, let's collapse it. This is all you get. All right, so now it's collapsed. Okay, if I collapse one of my lungs, is it going to get all the oxygen that it could get normally?
No.
Okay, and if it doesn't get all the oxygen that it normally should get, that means all that oxygen doesn't make it into the across the capillaries, it doesn't make it into here, and it doesn't make it to here. So in a tension pneumothorax, what sign am I going to have?
Altered mental status.
I'm going to have altered mental status, but when enough blood doesn't make it through here, are they going to have respiratory distress?
Yes.
So they're going to have increased respiratory rate with symptoms. If they have increased respiratory rate with symptoms, are they going to have increased heart rate with symptoms?
Yeah.
Yes.
Okay. And then as that pressure continues to build and build and build and build and build, let's say I'm over here, I now press on this inferior vena cava. What am I going to do to my blood flow?
Decreased flow.
Oh, wait, now I have decreased blood flow. When I have decreased blood flow, how does the heart have to compensate for it?
Yes, pump harder.
Aha. So now I have increased heart rate with symptoms. Do you know that I could literally just do the same thing? Like I'm going to get back to the same answer no matter what the problem was. So in that example, I used a tension pneumothorax and we got those exact same symptoms. Let's take a cardiac tamponade. Let's talk about, now I want you to do this. I want somebody else to try to take a stab at this. Jonathan, you want to try it? Or Maris, you want to go?
Sure.
We'll do about 15 more minutes and then we'll cut it off. Let's go, Maris. So, number 8. Okay. You got to connect cardiac tamponade. Okay, so what is the big things that we got to know in cardiac tamponade? What's the Beck's triad?
Muffled heart tones.
All right, hold on. So cardiac tamponade. All right, now we have so Dr. Beck came up with this Beck's triad. And what did you say we have?
Muffled heart tones.
We have muffled heart tones. Okay. Another way to say that is distant, faint heart tones. Okay. Difficult to hear heart sounds. Okay. That's muffled heart tones. What else do we have?
Hypotension.
Hypotension.
Okay. What else?
JVD.
Okay. JVD or bradycardia? Which one?
JVD.
Huh?
JVD.
Okay. All right. So you want to go with JVD? No problem. Now we got to explain each one of these things. Like we don't just need to memorize a random list. We need to actually understand why this is happening. Let's start with a muffled heart tone. So first of all, what is a cardiac tamponade? What is it? Let's level 1 knowledge. The what is it? So level 1 knowledge.
The cardiac sac.
Say it again.
Blood filling the cardiac sac.
Okay. So out here in the pericardial sac, all right, blood is supposed to be inside the heart, but instead that blood says, I'm leaking, and now I'm going to get outside of the heart in the pericardial sac. So let's put a whole bunch of blood out here. Now, when you put a whole bunch of blood out here, and I'm listening over their chest, and I'm listening through blood instead of air, it's going to make those sounds really muffled. Make sense?
Mm-hmm.
Okay, that makes sense. But where does the JVD come from? Why do I have JVD?
It's pushing, adds more pressure as it keeps filling and pushing on the vena cava. I'm sorry, causing.
Okay, not exactly.
Backing up, causing
okay. There you go. It's the backup. It's because when the heart has all this pressure coming from the outside, that prevents the heart from actually contracting properly. And it has to contract for blood to move in the correct direction. But when it cannot contract properly, blood cannot move in the right direction, so it backs back up. So now we're going to have a backup of blood. For instance, let's say blood is supposed to get out of this right ventricle, but instead it can't do it. So it backs back up to the right atrium, and then it backs back up to the neck. And now we have JVD. Okay? That's our JVD. So we've discussed muffled heart tones, JVD. Where does the hypotension come from? Why do we have hypotension in cardiac tamponade? So where's the blood pressure actually measured? Like when we put a cuff on somebody's arm, we're approximating the blood pressure where in the body? Okay, it's right here. So as blood leaves this left ventricle right here, LV, left ventricle, it goes through the aortic valve and it gets into the aorta. So we're measuring the blood right here on the other side of this valve, right about here. That's afterload. Okay. The amount of force that it takes to push through this valve to get blood through this aorta, that's called afterload. And blood pressure is actually measured right here. This is the highest pressure in the whole body, is right after blood leaves this left ventricle and gets in the aorta. But if there's no blood in the heart, no blood makes it here, to the lungs, back in the left atrium, back in the left ventricle. If there is no blood that makes it to the left ventricle, it can't go out of the left ventricle. Therefore, the body doesn't detect it as blood pressure, so it detects it as a low blood pressure. That's why we have hypotension. So give me all of that back. So Mary, since you're there, explain muffled heart tones, JVD, and hypotension in the setting of cardiac tamponade, the Beck's triad.
So the muffled heart tones generally occur because there is blood surrounding the heart, not in the heart. And so it makes it more distant. You're not able to hear through blood as well as you would through air.
Okay.
The JVD is because of a backup. So due to I'm freezing.
Okay.
Because
Since blood is not
blood is
able to
backing
pump
up.
in the normal direction, it backs up. And then, for instance, it backs from the right ventricle up into the right atrium. And then remember how it came into the heart. It came through the superior vena cava, the inferior vena cava. So as it goes toward the upper body, it's going to make the neck veins bulge out. As it goes toward the lower body, we'll have, for instance, edema later, kind of like with right-sided heart failure. Okay, tell me about the hypotension. Where does the hypotension come from? Why do you have hypotension in Beck's triad or in cardiac tamponade? Where's that blood pressure measured again?
In the aortic valve or the aorta?
So in the aorta. So right as soon as it gets into the aorta, that's where the afterload is. But if the blood is not inside of the heart and instead it's outside of the heart, there's no way for the body to measure it as inside the aorta because it never got there. It's just floating around in this pericardial sac, but not inside the heart so it can have normal blood flow. Does that make sense?
Yeah.
Not really?
No, it does. My mind keeps saying it's like falsifying the blood pressure because it's not actually reading a blood pressure.
Okay. And so
my mind keeps telling me
you could call that relative hypotension. It's not that you lost the blood, like it's not on the street somewhere. It's still like inside the skin, but it's not inside the heart and the blood vessels where it's supposed to be. Okay. Instead, it's filling up this pericardial sac. So what's going to happen? If now the body says, wait a minute, my blood pressure, all right, so let's use the same picture and come up with an answer. If my body says, uh-oh, my blood pressure is low, what's going to happen to the heart rate to try to counteract this low blood pressure? What happens to the heart rate?
It's going to increase.
Whoa, increase heart rate with symptoms. Okay. Now, wait a minute, as we keep increasing the heart rate, what's going to happen to the stroke volume? As we keep increasing heart rate, what happens to stroke volume?
Decrease.
Lower.
Okay. So they already were not pumping much blood because it's not in the heart. It's actually on the outside of the heart. But as the stroke volume decreases even more, now they have even worse perfusion. Okay. So as they have even worse perfusion, the heart tries to keep compensating by going up even more. But eventually the heart says, I can't do it anymore. You're stressing me out. So now the heart rate starts to go down. Okay. But then what if the heart rate just keeps going down? So now I have bradycardia. I have symptomatic bradycardia and they're unstable. Oh, wait a minute. Symptomatic unstable bradycardia. What do we do for that?
Pacing.
Oh yeah, that's probably a need for transcutaneous pacing. Now, what if they have like, if this results in maybe a second degree type 1 block, what am I going to do for that?
Atropine.
I'm probably going to use something like atropine. Okay. But what if I just get it I go down to 40, I go down to 30, let's go down to 20. Let's just keep dropping it. Let's just go to 0. Oh yeah. Oh, well, now I'm in cardiac arrest. Okay. So there again, they had one perfusion problem that manifested in another, that got worse. They decompensated. This is how everything ends up in cardiac arrest. And I could literally just do this for 20 more hours. But what I want you to do is I want you to take every situation, take this one picture. And I want you to explain congestive heart failure, explain pulmonary edema, explain asthma, status asthmaticus, a seizure, explain opiate overdose, benzo overdose, carbon monoxide poisoning, we could literally take any situation and I can get it down to this one picture. But it's not so important for me to be able to do that. I want you to be able to do that. Now, and I want you to actually practice with it. Just take a random scenario and take this one picture and say, wait a minute, can I explain why I'm going to have all the symptoms? And you're going to see the pattern just keeps coming over and over and over. It all started at a different point. The end result, left untreated, all ends up the exact same way. And you notice how we started off with tension pneumothorax and we got to the exact same signs and symptoms. We started off with cardiac tamponade. What do you think would happen if I start off with pulmonary embolism? You think I'm going to get you back to the exact same signs and symptoms? Okay, that's the pattern I want you to see. Now, all right, we're going to, because I could just do this for hours, but we're going to stop. What did you think about this tonight?
I think it was a fun impromptu. I got a lot out of it.
What did you get out of this, Maris?
I have some difficulty sometimes determining or distinguishing like what exactly fits into airway breathing, circulate, or I'm sorry, oxygen, ventilation, perfusion.
Okay.
When I read an actual question pertaining to the patient, sometimes I have a little bit difficulty, and that tonight kind of made me see a little bit better as to how to break that down, to get a better understanding of what goes where.
Okay, cool. Jalen, what did you think?
I really enjoy knowing why something is, because if you understand why something is, it helps you with solving the problem or answering the question better.
Okay. Absolutely. Not only that, though, it helps you in real life when you're not doing a test question in real life, because that's actually where it matters more. In real life, when you have a patient who's sitting there dying on you, like knowing like 10,000 PowerPoints doesn't really make a difference at that point. We got to get it down to, I got to fix an oxygenation problem, a ventilation problem, or a perfusion problem, and I got to fix it now. Okay. Here's what I'm going to do. Okay, let's say you just have a question. All right, they give you, let's take a burn. Let's take a house fire. I'm just doing this on the fly. We're going to take a house fire. Okay? Patient gets a house fire. They've got carbon monoxide poisoning, and that carbon monoxide is binding to the hemoglobin instead of oxygen binding to the hemoglobin. And if the carbon monoxide is taking up the seat on the bus, instead of oxygen sitting in the seat on the bus, there's no oxygen to circulate. So if the oxygen doesn't make it into the bloodstream because carbon monoxide is there instead, now I have carbon monoxide that goes here. Now, if I don't have oxygen going to the brain, what's going to happen?
Altered mental status?
Okay, so in carbon monoxide poisoning, we're going to have altered mental status.
Yeah.
Okay. Now, but let's see if the pattern works, because I'm telling you, it works for everything. But let's just see. Now, okay, if I don't have oxygen, so this was a house fire with carbon monoxide poisoning. I don't have oxygen. What's going to happen to the heart rate if I don't have enough oxygen?
It's going to increase.
Oh, snap. We're going to have increased heart rate with symptoms. What happens to the respiratory rate in carbon monoxide poisoning?
This is going to increase.
We got increased respiratory rate. Now, what happens if the respiratory rate just continues, and then the body says, whoa, I can't do this anymore. And then I start getting tired. What happens? What happens to the respiratory rate?
Starts to fall.
Now I'm going to have decreased respiratory rate with symptoms. Oh, wait a minute. When I have decreased respiratory rate with symptoms, what's going to happen to my CO2?
It's going to rise.
Okay, my CO2 starts to rise. So if I were to put capnography on, I'm probably going to see an end-tidal CO2 greater than 45, 50, 55, 60. Okay. All the CO2, what's that going to lead to?
Acidosis, vasodilation, shock.
Okay. When I have all this acid that gets into the blood, what happens inside the brain?
Altered.
No mental
Okay,
status.
so we're going to have altered mental status. What are we going to do to the blood vessels inside the brain?
They're going to dilate.
Dilate them.
Okay, we're going to dilate the blood vessels in the brain. Now I'm going to have increased volume in the brain. Now I'm going to have increased pressure in the brain. So if I have increased pressure in the brain, that all that pressure now is going to start herniating the brain. It's going to wipe out the respiratory center. Now we're going to stop breathing, And now this is how your carbon monoxide poisoning patient ends up in respiratory arrest when you see them. The reason they're not breathing, and now this can happen very quickly, depending on the concentration of the carbon monoxide in the atmosphere. Obviously, when you have a little bit, it takes a longer. But as that car continues to run inside of that closed garage and we have more and more carbon monoxide filling up the space, the problem is it's colorless, odorless, tasteless. We don't know it's there, but so they can progress very quickly. It can, like, almost immediately. It's because there was so much to start with. And now that same carbon monoxide poisoning patient ends up in cardiac arrest. Can you see, like, are you starting to believe that this pattern works for everything?
Mm.
Okay. We could take anaphylaxis and do the exact same thing. We could take a seizure and do the exact same thing. Oh, wait, hold on. Let's do a seizure. I want somebody to make the connection for me. In a seizure, Jonathan, you still there?
Yes, sir.
What are you thinking so far? How's this session going? We got like 3 minutes and we got to call it.
Oh, it's awesome. It's a lot to pick up on, but I definitely see where it's going to help me.
Okay. All right.
Yeah.
So let's go. Jonathan, you got a seizure patient.
Yep.
All right. This patient's seizing. Now, when they're seizing, what are they not doing well when they're seizing?
They're not
And all
breathing
that,
well.
huh?
They're not breathing well.
Oh, check this out. So we got a seizure patient. Oh, wait, if they're not breathing well, that sounds like a ventilation problem. But if
Yep.
they're not taking air in, that's an oxygenation problem. If they're not blowing the air out, that's a ventilation problem. Okay. All right. So let's say this seizure patient who stops breathing or not breathing well. Wait a minute. Their respiratory rate's going to probably do what if they're not breathing well? Or let's say they're
Increase.
not breathing, like they're breathing inadequately. What happens to the respiratory rate eventually?
It's going to decrease.
Oh, snap. Respiratory rate decreases. As that respiratory rate decreases, what happens to the CO2?
Increases.
CO2 increases. That's going to lead to acidosis. That acidosis is going to lead to vasodilation, especially in the brain. Okay. And then that vasodilation, as it happens in other blood vessels, is going to ultimately lead to shock. So this is how your seizure patient ends up in shock. Why is the seizure patient postictal? Why does the seizure patient have that period of postictal state where they're confused, they're altered? Oh, well, hold on. Give me a connection. Go from seizure to postictal from the picture.
Acid or
Okay. So my man says they're not breathing well. They got too much CO2. That CO2 is going to lead to acid. All right. So now we've got carbonic acid. We got extra hydrogen. That leads to respiratory acidosis. That acid is going to get in the blood. Where's that acid going to go next?
to the brain.
All right. As that acid goes to the brain, what happens to the
Vasodilate.
brain? Okay. We're going to have vasodilation. So that's called cerebral vasodilation. All right. Now, as we get more and more dilation in here, we're going to increase the blood flow in the brain. What's that going to do to the pressure inside the brain?
Increase.
That's going to increase the pressure. What's that going to do to the brain overall when it's flooded up with acid? Is it going to function well or not function well?
Not at all.
All right, so they're going to be really sleepy, except now we don't call it sleepy. We call it postictal. Same concept, just a different name on it. It's the exact same thing. Are you starting to see the patterns here?
Oh, yeah.
Okay. I promise you guys, we could do this 1,000 more times. We're going to get to the exact same endpoint. This is one of the most important concepts to know in everything we do, but yet, how many of your paramedic schools taught it this way? What about yours, Jonathan?
It would have been way easier to learn this way.
Okay. Because they taught you the what. They said, oh, it's seizure patient postictal. They didn't teach you the how. They didn't teach you the why. Can you see how knowing the how and the why helps you in a lot of situations, not just on a test, but it actually helps you in real life. And that's where it matters more. Because long after the test, you're going to be like, you're going to go on a call at midnight and you got to have a patient that they have an oxygenation problem, a ventilation, or a perfusion problem. But if I can get it down to this, I'm not having to like think about so much. I really only think about 3 things. And I figure out, well, what do I need to do right now that's going to help one of these problems? They may have more than one problem at a time. They may have an oxygenation and a perfusion problem, or they have an oxygenation and a ventilation, or they have a ventilation and a perfusion, or they have an oxygenation, ventilation, and perfusion. So what do I do when they have multiple problems at the same time? I figure out which one of these
Kill them
problems kills
first.
this patient in the next minute.
Yeah.
And I fix that. And once I fix that problem, I say, what is the next problem that kills this patient in minute number 2? And I fix that. and sometimes I'm just doing the best I can. But what I'm going to do is I'm just going to keep fixing the next problem that kills the patient. And eventually, I'm at the hospital. Hey, doc, it's your turn. I've done what I could do, but at least do what you can do. Okay? As opposed to just like typing on your laptop or charting while you're trying to take care of a sick and dying patient. Okay? Like I never chart in the back unless it's like a long distance transport. But if it's like an ALS call, even a BLS call, I'm not charting because things can change very quickly. You saw how we can go from ischemia to cardiac arrest like in seconds. Okay. What questions, guys? This was really fun for me tonight. I hope this helped you kind of understand more about the how and the why. And as you continue learning, your knowledge is going to keep escalating higher up. You're going to keep ascending up the levels of learning. Can you see why I have so much fun now? There was a time period where I didn't have as much fun in medicine. It was when I didn't know enough. But as I started learning more, as I started making more connections, especially learning the how and the why, then it's like, okay, I want to see how many times I can apply this on a patient. Now it becomes fun. It's not that I know all the answers, but I get closer to the right answer more times because I know more. And I want you to do the same thing. I want you to keep growing in your knowledge, keep learning more, keep understanding more, keep asking questions, and we'll just all continue growing together. I hope this enriched you in some way today, and I hope it added value and made a few more connections for you. What I want you to do, what I challenge you to do, take a blank piece of paper, and I want you to just recreate this. Okay? I'm telling you, this one page, like I want you to see just how many scenarios you can come up with an answer off this one page. Any questions, anybody? Any questions?
Not a question, just thank you.
You are certainly welcome. You're certainly welcome. And when are you testing, my man?
I'm looking to test as soon as I get done with the 21-day course. I think I have
Okay.
it scheduled for the 9th or the 11th.
Okay.
One of those days, whatever is close to the end of that.
Does that give you the full 21 days?
I think it'll give me 20 days, but I think
Okay,
on
that's
one of my
fine.
3 days, I'm going to try to do more on one day.
Okay, that's no problem. If you get stuck at any point, just reach out. And you've got lots of people in the community that can also answer the question. So it doesn't have to go to me. You can just make a post in the community and somebody will probably know the answer. But if nobody knows it, just send me a message and I'll answer it. Obviously, you guys can imagine, when I logged in earlier today, I think I had 22 messages. And so I've answered I've got 2 more now. But I answered every message until these last 2. Jalen, did you see my response to you earlier?
Yes, I did. I have to read them over again, but I seen them.
Okay, I think it was
Yes,
about,
sir.
you asked me a question about neonatal resuscitation.
Yeah, it was the resuscitation and just knowing when to ventilate and when to do CPR.
Okay, so let's talk about it. So when it comes to neonatal resuscitation, so yes, it is true that the guidelines support that if the heart rate is less than 100, we're going to do positive pressure ventilation, okay?
Mm-hmm.
But let's say the heart rate is 55. It's not that we immediately go to chest compressions. Yes, we are supposed to do chest compressions once the heart rate goes to below 60 in neonates. So that's from the time of birth up to 1 month old. But because all right, let's go back to the exact same thing we've been talking about. Notice the progression here. Before we get to cardiac arrest, we're in respiratory arrest. But before we're in respiratory arrest, we're in respiratory failure. So if you have a neonate whose heart rate is less than than 60, they're probably in respiratory distress or respiratory failure, more likely respiratory failure, where positive pressure ventilation may actually fix the problem and you don't need to do chest compressions at all. So we're going to still go ahead and treat this as a ventilation problem with positive pressure ventilation through a BVM. However, if in a short period they don't improve and the heart rate does not go back up, now we're going to treat them like they're in cardiac arrest and go straight to chest compressions. But we start with ventilations first. Okay?
Okay.
Okay. Anything else? All right. Well, guys, this was fun for me. I hope you enjoyed it. Continue to reach out if you have any questions, and we'll go ahead and end it for tonight unless you have any questions. I'll stay on if you need me. Otherwise, we'll hang up.
Thanks, Coach.
Give me a thumbs up or down if you need me.
Good. Thank you.
I'm good,
Okay.
Coach. Thanks.
All right, good. You guys have an amazing night, and thanks for coming on with me.
You as well. Thank you.
All right. Have a great night, everybody.